Thank you so much, and thanks to Jalid for the kind invitation and having us join here. And wonderful to see everybody. And Mansour, really emotional to hear your presentations. Our patients really deserve this great news, and hopefully EMA and FDA will approve for proficient and deficient patients really need this. So congratulations. So this is a little look at surgical approaches. I have no disclosures here. And again, for the majority of patients that we see in clinic, they come in with what looks like uterine confined disease. This is the vast majority of patients. And again, the objective of surgery here is really twofold. One is to remove the cancer, which is the hysterectomy and removal of the tubes and ovaries if there is no concern for trying to preserve the ovaries or uterine preservation for fertility. So for the vast majority of patients, it is total hysterectomy and BSO is the treatment for the cancer. The second part of the operation is really with one objective. Are cancer cells contained inside the uterus or are they outside of the uterus? That's why we do staging. That's why we do washings, peritoneal biopsies, omental biopsy, and that's why we remove lymph nodes, is to try to find out, are cancer cells outside the uterus? And this is really depends on how we do things in the OR and how the pathologist examines this. And we believe that women with endometrial cancer should be treated by gynecologic oncologists. It's a disease on the rise in the United States. Mortality is on the rise. We're going to become what ovarian cancer was or remains now. We're going to supersede and pass ovarian cancer with mortality. So a lot of work needs to be done in endometrial cancer. And we believe that surgical staging, and again, this is the discussion here, is that we believe surgical staging with an SLN algorithm, when patients leave the OR, at the minimum, in addition to the hysterectomy, you have your washings and you have bilateral pelvic nodes. In most cases, that's in about 95% of cases, to help you stage and guide therapy. So the purpose of this is to assign risk and guide therapy. And again, this may change and we need to be flexible about how we do this in the future. And again, we've done tremendous work with colleagues in the Mayo Clinic, and honestly, without our colleagues in the Mayo Clinic and the leadership of Professor Podratz and Dowdy and Mariani, and now with Gretchen Glaser also leading the endometrial program, without really teaming up with the Mayo, we probably would not have been able to move the needle on standardizing surgery for endometrial cancer, at least in the United States. We believe that there is increased precision with SLN mapping because of how we do the operation. And although the pathologist is getting fewer lymph nodes, but these lymph nodes are much more enriched if there is metastasis. So in the 90s, and I had 10 partners at that time, and we really, you would ask each one of them and you would get a different answer. The fellows were really getting confused. What surgery we do? Who do we need to remove lymph nodes? How far? How deep? How high? How low? And do we send for frozen? Do we do MRI? So really the question was, for the majority of patients with apparent uterine confined disease, as GYN oncologists, could we come up or design one reasonable primary operation that really focuses on our patient and serves our patients well? Most of us can do with good quality. And again, we can teach and we can standardize. And I think where we are now, the answer is yes. A lot of what we had written in guidelines before was not being practiced. Maybe 10, 15% of us were actually doing what we had said we would do, but I think today the vast majority of us are able to do this. And I strongly believe that surgery remains the absolute primary treatment for this disease, and it is the absolute gold standard for staging. We still don't have the precision with imaging, whether it's MRI, whether it's PET scan, to really find this microscopic disease. Surgery is the most powerful tool, and again, will remain most likely the most powerful tool for many years to come. This is an example of PET scan study done at the MD Anderson, and you can see the false negative rate, 54%. So if you still remove lymph nodes as part of your routine staging for endometrial cancer, using SLN mapping is a reasonable strategy and will add precision to your surgical approach and may actually decrease side effects to our patients. You may say, I don't need lymph nodes, I can just go by uterine factors, and that's absolutely fine. And we may get to a time where that would be the strategy. But for now, especially in endometrioid histology, removing lymph nodes is very useful. So if you look at the list of histologies, I think it's very useful in endometrioid. In serous, some people can make an argument, well, we're giving everybody chemotherapy. Well, in some institutions like ours, if you're surgically staged, you have negative wash, negative bilateral nodes, non-invasive lesion, we don't give chemotherapy. It may change, but for now, we only give chemo if you have X-ray trine disease or myoinvasive disease. So surgical staging remains valuable in serous. Same with clear cell. You can make an argument for carcinosarcoma. Why are we even removing lymph nodes in carcinosarcoma? What's the point? It's not going to make people live longer, and everybody's going to get chemo. So that I would submit maybe something we can de-escalate. But for most endometrioid, I think it's very reasonable. The next question will come, well, why are you asking us to remove lymph nodes in low grade, grade 1 or grade 2, endometrioid, that's less than 50% invasive? It's invasive, but it's shallow. The answer is LVI. You cannot determine LVI on a DNC, on a biopsy, on an MRI, or ultrasound. If you have grade 1 or 2 endometrioid with myoinvasion, less than 50%, and LVI, nodal positivity now jumps to 11 to 16%. So until we are able to determine LVI before hysterectomy, and I think I submit that even at frozen section, it's very hard to determine LVI. So my answer is for the low grade, because you really don't know LVI, it is still useful to do the SLN mapping. If you look at our data, this is almost 1,000 endometrioid, all had bilateral pelvic mapping. If you look at the grade 1 and 2, shallow invasion, this is all comers, with or without LVI, it's about 5%. I'm not adding the ITCs, this is without ITCs. If you enrich it to LVI, it jumps to 10 to 11%. So LVI is a big factor in nodal positivity in this disease. So what is the adequacy when we stage these patients? I think we need to move away from counting lymph nodes. We talked about this earlier today. So really the quality metric now, the surgical metric, and the culture should be bilateral mapping, even if it's 3 lymph nodes or 4 lymph nodes. You don't need 15 or 20 lymph nodes. Gone are the days where the quality of your pathology report is dictated by the count of lymph nodes. In fact, you can make an argument in most of these patients, you don't need 20 lymph nodes, you need 4 or 5 lymph nodes, and patients are well staged if you have bilateral mapping. So it's really finding that positive lymph node, and it's what we do in the OR and how the pathologist examines this. Technology is helping us. The film study with ICG versus blue really led to the determination for sure that ICG is superior to blue, and led to FDA approval. First time in GYN surgery, we have now a technique and approach approved by the FDA for cervix and endometrial cancer. But we still have to be careful with the 5 to 6% empty package, because when patients leave the OR, they have to have bilateral nodes. Otherwise, we did not serve them well, and then you really go back to the dilemma of treating biuterine factors. It is a very safe dye, as we spoke earlier today. This is a study from our group. And again, this question of cervix versus hysteroscopic injection, and I give a lot of credit to Professor Raspagliese, who was a pioneer in hysteroscopy, but actually did this study comparing cervix to hysteroscopy, and basically closed by saying cervix injection is the way to go. So there's no more discussion about the cervix injection. It is the way you go, as you saw this morning. And Professor Muallim this morning really showed us a beautiful demonstration of the anterior paracervical pathway shown in blue, the posterior paracervical pathway retroureteric shown in green. So really, there is precision. We know where to go. We know where to find these lymph nodes. We can teach it, and it is scalable. People leave fellowship and can do this in the community. As far as side effects, Mario from our group, Leteo, did a patient survey. And really, for the first time, from a patient-reported outcome, patients reported that SLN mapping independently resulted in significant lower leg lymphedema. So we have some feedback from patients saying folks who had SLN, they have less lymphedema with endometrial cancer. Our colleagues in Brazil did something similar, looking at lymphocyst formation. And again, for the first time, we have lymphocyte 3% with SLN versus 14% with lymphadenectomy. So we are probably also decreasing side effect with increased precision in surgery. I think in January 2014 was a turning point for me when I visited the colleagues at Mayo, and really at that point resulted in a tremendous sharing of databases, openness, and discussions that have helped me, and I learned a lot. And I think together we were able to publish these 5 papers that really looked at initially endometrioid shallow invasion, comparing SLN versus lymphadenectomy. And you can see the detection rate is adequate. It's 4.8 with SLN, 1.8 with lymphadenectomy. And again, although the total number of lymph nodes with lymphadenectomy is much larger, 34, removing less lymph nodes still resulted in a 5.1% detection rate. So we did not need to remove 30 lymph nodes. We can really be more precise and still find this disease. Oncologic outcome with recurrence and with survival was terrific for both groups. This is a low-risk group. We then looked at, well, can you actually, with SLN, find those positive nodes if you had an endometrioid deeply invasive or a serous cancer? And we compared lymphadenectomy to SLN, and you can see that SLN detected positive nodes 35% of the time, lymphadenectomy 28% of the time. So SLN provided similar detection rate to standard lymphadenectomy. So that's why we say it's reasonable as lymphadenectomy. If you look at oncologic outcome for endometrioid deeply invasive, you can see here that even the SLN group had more LVI. And again, here, the total number of lymph nodes, of course, will be higher with lymphadenectomy, 34 compared to 10. Positivity is still as good with SLN, and most importantly, with the reduction in the removal of lymph nodes for deeply invasive endometrioid, progression-free survival, overall survival, there was no detriment. Then we looked, well, what if you have positive lymph nodes, microscopic, not bulky nodes? Does removal of more lymph nodes really matter? And again, this was led by the Mayo group. And again, with removal of more or less than 10 lymph nodes, there was no difference. So unfortunately, even if you have positive node, the removal of more normal appearing lymph nodes did not make people live longer. Of course, all of this is retrospective data comparison, but it is the data that we have from both of our institutions. And then finally, we looked at the higher risk group. Those are with the serous clear cell comprehensive lymphadenectomy versus SLN. And again, we were not able to show a definite survival advantage for complete lymphadenectomy, even in the serous group. For the serous group, we were very interested internally. We looked at 245 memorial patients, SLN versus lymphadenectomy. What's very interesting is the SLN group had just bilateral mapping with a total of 3 lymph nodes compared to 18 for the lymphadenectomy. None of the SLN had periodic nodes. So not only we were removing less pelvic, we stopped removing periodics. This is in serous cancer. And you can see our 2-year overall survival for stage 1 and 2 and stage 3, there was no difference. And these are the survival curves. So even in the serous group, with abbreviation of the pelvic procedure, elimination of the periodic node dissection, we really were not able to see a detriment in this group. We did the same with the carcinosarcoma. SLN removes 4 lymph nodes, lymphadenectomy 19. You can see the survival curves here, no difference in abbreviating the surgery for carcinosarcoma. The trends with SLN mapping have dramatically changed since 2012, I think, particularly with the NCCN acceptance of this after 2014. The adoption in endometrioid and non-endometrioid is on the rise, and I think the use of backup lymphadenectomy, as you can see on the right side curve, is diminishing with time. You can make an argument to maybe use it in some atypical hyperplasia. I'm not convinced. I think most of these patients don't need SLN, and again, we can have a discussion about that. Of course, the last couple of slides, when you think of our patients with morbid obesity, SLN is suitable. You can do it minimally invasive. You can get to the pelvic nodes. You can stage these patients. And again, as we deal with this disease more and more in a challenging large body mass index and difficulty with patient positioning, more and more precision with minimally invasive surgery in SLN would be the way to go. Last slide, we are moving in the right direction. There's definitely increased precision in surgery with endometrial cancer. I believe women with endometrial cancer should be treated by GYN oncologists. Progress has been made and will continue to benefit our patients. And again, standardization of this initial surgical approach, which is what the vast majority of patients will enter the door through, is a significant advancement, and we need to continue to work on it. Thank you so much.
Thank you, Nadeem, for leading this change, important change in endometrial cancer surgery during the last decade. Thank you for that. And I would like to introduce Dr. Gretchen Glaser. Gretchen Glaser is currently leading the endometrial cancer research at Mayo Clinic. She is the site PI for Mayo Clinic for the SELECT trial. She is also a dear friend and colleague, and I'm very, very happy to introduce him.
Thank you. Thank you. Good afternoon. Thank you so much for having me here today. It's really been an amazing meeting so far. And I really would like to thank Dr. Sahuli and Dr. Blomer for having us here today, for bringing us to this beautiful city of Berlin. It's my first time here, and again, the meeting's just been awesome. So sentinel lymph node biopsy has been really revolutionized surgical staging of endometrial cancer, as so well discussed by Dr. Abu-Rustum. And at Mayo Clinic, we perform sentinel lymphadenectomy according to the MSK and now also NCCN algorithm, including patients with low and high-risk histology. And as Dr. Abu-Rustum discussed, sentinel lymph node works. And in fact, it works better for diagnosis than full lymphadenectomy. This is a meta-analysis by Howe and Gottlieb in 2018, which determined pooled estimates for sentinel lymph node detection rate and diagnostic accuracy. In 48 studies, including over 5,300 patients, sentinel lymph node detection rate with ICG was 94% overall, with pooled estimates showing 94% sensitivity and 100% negative predictive value. And so then we go to prospective studies, of course. We all know the FIRES trial, and also prospective validation from Memorial Sloan Kettering in high-risk histology, as well as a systematic review in high-risk histology. All of these showed similarly excellent outcomes for sentinel lymph node biopsy. So our next question. Are oncologic outcomes compromised by not performing a lymphadenectomy and instead performing sentinel lymph node biopsy? This is a retrospective study from 2017 showing fewer pelvic sidewall recurrences in patients who had sentinel lymph node biopsy than in patients who had lymphadenectomy. So sentinel lymph node biopsy is finding those positive lymph nodes more often than lymphadenectomy. As Dr. Abu-Rustum discussed in detail, and I'm just going to say quickly, Mayo and Memorial Sloan Kettering have had a very fruitful collaboration over many years to investigate this question retrospectively, including joint papers published every year for several years over different risk subgroups showing similar diagnostic outcomes for sentinel lymph node biopsy versus lymphadenectomy, similar ability to identify positive lymph nodes, and similar oncologic outcomes. Both institutions have also investigated and published on lymphedema after sentinel lymph node biopsy using patient-reported outcomes, and this is as opposed to lymph node dissection or lymphadenectomy, and it showed that with the former, there's actually no increased risk of lymphedema in patients who have hysterectomy with sentinel lymph node biopsy over just hysterectomy alone. This is just such a huge benefit for our patients. So that's retrospective. What about prospective? Well, that's where the SELECT trial comes in. So both Memorial and Mayo, and it started at Memorial and also we're collecting at Mayo. Many other national and international institutions are collecting patients. The primary objective of this trial is prospective, multi-center, single-arm observational trial looking at patients with stage 1 intermediate risk endometroid endometrial cancer with bilateral negative sentinel lymph nodes and assessing their 36-month incidence of pelvic non-vaginal recurrence in comparison to historical controls. In this trial, patients can receive vaginal brachytherapy or no adjuvant therapy, and our secondary objectives are to look at things like lower extremity lymphedema, quality of life, surgical morbidity, as well as our rate of successful mapping and empty node packets. Okay, so our best plan is to inject the ICG, open the spaces, and remove the sentinel lymph nodes. And today, I have been tasked to address the question of, is there a time to do the sentinel lymph node biopsy, but if it doesn't map, what do you do? Do we always do the hemipelvic lymphadenectomy? Are there any special situations in which we might not pursue the site-specific lymphadenectomy in the case of unsuccessful mapping? And then on the other hand, what about when we get a positive sentinel lymph node, either on a frozen section or postoperatively, 7 days later? Do we need to go back for all the nodes in that case? So first, let's talk about unsuccessful mapping. This happens for a variety of reasons. This is a study we did at Mayo. Increased BMI, the volume of dye injected. We heard this morning that it can be different at different places. The number of procedures performed by the surgeon and other factors. So this is our study. We also showed that lysis of adhesions at the beginning of surgery, possibly due to obstructed lymphatic channels from prior surgery, and clinically enlarged lymph nodes were associated with unsuccessful mapping, as was surgeon experience. As your number of cases went up, your successful mapping went up, and I know that's been shown in other places as well. And I want to emphasize that at Mayo, we believe in the protocol and the guidelines, and we follow the guidelines. Sorry about that. Of performing a side-specific lymphadenectomy on an unmapped hemipelvis. And that's because these guidelines make a lot of sense. There's always a possibility that the reason you're not getting mapping is because there's disease in that lymph node. And I know for me, that keeps me up at night. Thinking that I've missed the node that has the disease in it is very scary. So, but this is meant to be a debate, and I am meant to take the no sentinel lymph node side, so here we go. Are there any special situations in which site-specific lymphadenectomy can be avoided? So, this slide you already saw. One of the first things we can try with unsuccessful mapping is to re-inject the cervix. So use the same exact protocol again, same volume of dye on the unmapped side of the cervix, using the same NCCN MSK protocol. This is a study from the European Institute of Oncology that showed that cervical re-injection successfully increased bilateral mapping from 73 to 95% and also decreased unilateral and no mapping. This could really help us with site-specific lymphadenectomy. Okay, so what if you failed mapping, you re-injected, you still have unsuccessful mapping? In most patients, the answer here is site-specific lymphadenectomy. But maybe there's a small group of patients who have low-grade disease and are in a center with robust frozen section who could be evaluated by frozen section to see if they also meet the Mayo low-risk criteria and in the past may have not received a lymphadenectomy at all before the innovation of sentinel lymph node biopsy. What I really want to emphasize here is tumor diameter. So Dr. Abu-Rustum showed us about LVSI in patients with superficial invasion, and of course, LVSI, like he said, is a postoperative diagnosis. I don't care how good our frozen section at Mayo is, they're not going to tell us about LVSI on frozen section. But in our study outlining the Mayo criteria for low-risk patients, 0 patients with a primary tumor diameter of less than or equal to 2 centimeters had positive lymph nodes, as opposed to 7% of patients in this otherwise low-risk group whose tumor diameter was greater than 2 centimeters. So I think this one factor makes a big difference. So what am I talking about with robust or accurate frozen section? So this is a study from Mayo approximately 10 years ago that demonstrated an 89% accuracy rate for our frozen section with only a 1.3% risk of having a clinically significant change that would affect postoperative management. And we know that it's not possible to reproduce this kind of accuracy rate everywhere, but there are other places that do. This is a study from Duke and Johns Hopkins looking at frozen section in unmapped patients and using the Mayo criteria to see if site-specific lymphadenectomy could be avoided. And in this institution, only 3.5% of their patients had a change at final pathology that would have been clinically significant. Okay, so this brings me to my next question. What if you're unmapped, you re-inject, you're still unmapped, and you have high-grade or non-endometrioid preoperative biopsy? In this case, there is no role for frozen section to figure out whether or not you should take the lymph nodes on that side. We should just go straight to site-specific lymphadenectomy. Okay, so now going back to our dilemma. Slide, we're going to focus on what to do when your sentinel lymph node is positive. So do we need to go back for the other nodes or complete the lymphadenectomy if we happen to get a positive SLN? And for this, we look to a lead article in Gynecologic Oncology in 2019, which is another great Mayo and Memorial collaboration, looking at survival and progression outcomes between patients managed with lymphadenectomy via the Mayo criteria versus sentinel lymph nodes via the Memorial criteria in patients with non-bulky stage 3C endometrial cancer. And what we found in this study was that in an equivalent number of patients with similar postoperative adjuvant therapy, the number of nodes removed at Memorial was lower, of course, but the adjusted 5-year cause-specific survival, progression-free survival, and lymphatic progression-free survival were not significantly different between the two cohorts. And assessment of the periortic area was performed in 100% of Mayo patients and 48% of Memorial patients. Things that predicted overall survival and lymphatic failure on univariate analysis were histology, cervical invasion, and chemo-RT as adjuvant treatment, and on multivariate analysis, grade and histology remained for both overall and recurrence-free survival. Chemo and EBRT improved outcomes, and lymphadenectomy was shown to be unlikely to be useful in these patients as they received chemo and radiation anyway. So you may ask, but what about the periortic area? In this same study, we showed that while patients having sentinel lymphadenectomy had more periortic progressions, the rates of isolated periortic progressions were similar and survival was similar. So what this tells us is that these patients tend to also recur in other places, concomitant recurrence that's not in the nodes, and so they have similar courses. Okay, so our take-home message to this question of whether we need to complete the lymphadenectomy with microscopically positive lymph nodes is no. Resection of gross, bulky lymph nodes, of course, is always recommended, and as Dr. Abu-Rustum said, especially in grade 1 to 2, because high-grade patients occur in distant fashion, and lymph node dissection is really a local regional treatment if you're going to take them all, just like radiotherapy. Okay, so how do we wrap this up? First, by just emphasizing that sentinel lymph node biopsy is a game changer in so many ways, and that it is our standard surgical staging at Mayo, including following the guidelines for site-specific lymphadenectomy. Second, in special situations with highly selected, low-risk patients in centers with robust frozen section, it may be reasonable to perform frozen section to determine possibility for avoiding a site-specific lymphadenectomy. And finally, in patients with stage 3C disease who have only non-bulky, microscopically positive lymph nodes, completing the lymphadenectomy is not necessary for equivalent oncologic outcomes. Thank you again. It was so great to be here. How could I possibly end a talk from Mayo without putting the Mayo brothers in here? And in addition, the Mayo brothers in our horrific winters, which are luckily coming to a close. Thank you again.